So thanks everyone for taking the time out. Grew up in Louisiana, but went to Stanford, so that's kind of what brought me to the area. Did my medical school at Vanderbilt, and then did most of my training down at Baylor College of Medicine down in Texas. So I have a fellowship that I completed specifically in continence, neurourology, and female pelvic reconstruction that I did in Houston as well. So the topics that I'm going to talk about today are the things that I focus on, but am also most passionate about. So where we're going with today's lecture, we'll focus mostly on urinary incontinence. A couple things are, what is urinary incontinence? How to So as you probably know, so urinary incontinence is the involuntary loss of urine from the body when you really don't want it. So it can be either frequent or infrequent. For some people it happens, multiple times a day. Other people it happens just every once in a while. And it can range from just like a little bit, like a few drops, to a complete emptying of your entire bladder. So certain things and activities like exercise or coughing, laughing, sneezing can sometimes trigger urinary incontinence. And then the most important thing or characteristic of this is that it can be treated. So some facts about urinary incontinence. It's a very common thing to have. In fact, about 18 million women suffer from urinary incontinence, and then 1 in 4 over the age of 18 end up having it at some point in their life. So it's about 2 times more common in women than men, most likely because women have to give birth to children. 1 in 10 women report weekly leakage. 25 to almost a half report occasional leakage. And then this next statistic really struck me, that women wait almost 6.5 years to talk to their doctors about their urinary incontinence. 80% of those affected by it can actually be cured by it. And so we'll kind of dive a little bit deeper into kind of why, what are some of the reasons why people kind of wait so long to get it taken care of, especially when it's treatable and really improves their quality of life. So some of the misconceptions are that, nothing can be done about it, especially in the older population range. Others are that they think that it's just a part of the normal aging process. Other ones are, pads. They think pads are the only way to manage it. And surgery, I think, frightens some people. In their minds, they think that surgery entails like a huge incision and that the recovery period is going to be long and painful. So this diagram here is a nice little overview of the urinary system. You see the kidneys up top, you have 2 of them. And then these tubes, the ureters, carry the urine down to the bladder. And there's a short urethra at the very bottom. So how the system works is that the urine comes from the bladder and the bladder fills. At some point, the bladder gets so full that the bladder will start contracting and squeezing. The sphincter has to open up for the urine to leave the body. And then once it's done emptying, the bladder relaxes and the sphincter closes. So that's the normal way of when everything's working okay. So let's talk about kind of what can go wrong then whenever you have urinary incontinence. One thing might be if the sphincter isn't strong enough when women do things like lifting, running, coughing, or laughing, the sphincter is not able to contain the urine from leaking out. The other thing that can sometimes go wrong is if the bladder itself is spastic and just starts squeezing and contracting, and the sphincter just isn't able to contain it. So those are kind of the two big categories of things that can go wrong. Risk factors for urinary incontinence include childbirth. You have a 1.3 to 2-fold increase, and this is one of these things that the more children you have, the risk increases. Spontaneous vaginal deliveries tend to be worse than C-sections. It almost doubles the odds of urinary incontinence. Body mass index, obesity is another one that almost doubles the risk of urinary incontinence. And then finally, hysterectomy. It's a 1.8 to 6.3-fold increase. If it's for benign reasons that it was removed, those are the lowest odds. But if women have pelvic organ prolapse as the cause of why they had their uterus removed, then they have the highest odds. So other potential risk factors might be aging, especially through the menopausal years. Now, age itself isn't necessarily the cause of urinary incontinence, but it might just be that as people age, they're more likely to kind of end up with these other associated risk factors like obesity or childbirth, pelvic surgery, menopausal replacement therapy, and then diabetes. Now, this list on the other side here, these are also possible things that have increased risk, but the verdict is still out because there's some conflicting evidence. Smoking, diabetes, depression, heart disease, socioeconomic status, high-impact exercise, estrogen replacement therapy, and then caffeine or alcohol consumption. So let me talk about the different types of urinary incontinence. I touched briefly on the ones on the left of the screen earlier, stress and overactive bladder. So let me kind of focus on the remaining three. So mixed urinary incontinence is exactly as what it sounds like. It's a combination of having both stress incontinence, where the sphincter isn't strong enough, and then also having urge incontinence. So I think one of the criteria for urge incontinence that is sometimes helpful to think if you have a problem is if you're going more than 8 times a day, or about less than every 2 hours, that can be problematic. Or if you're waking up more than once a night. Overflow incontinence is a little bit more unusual to have, but this is basically for some women who are unable to empty their bladder at all. And so the bladder just fills up, and the only way that the urine is able to get out is for it to kind of dribble out. And then finally, functional incontinence is if you have problems making it to the bathroom in time before a leakage episode happens. So those are the 5 types. We'll talk a little bit about how we diagnose it. Usually we get a good medical and surgical history just to kind of tease out if there's any risk factors, like hysterectomy or medications that you're on. Urination habits. Avoiding diarrhea is really helpful. This is a little picture of avoiding diarrhea on the right side here. But basically, I have patients sometimes fill this out just so that they can really record how much they're going, how many times they're leaking, and how big the leakage is. It just gives a really clear, objective idea of kind of where people are starting off from, so that if we do change something, you can kind of see how it impacts it. Other tests that we might do in the office include urine analysis, just to make sure that the symptoms aren't from like a urinary tract infection. Cystoscopy, which is a small camera that we put into the bladder to look around and just make sure that there's nothing concerning. And then finally, urodynamics, which is a test that we do with these catheters that we put into the rectum and the bladder and start filling it up and try to kind of reproduce the situation where people end up having urinary leakage. Treatment options for urge incontinence. They can include non-surgical things, protective undergarments, medications. There's a whole slew of medications that are available these days for treating urge incontinence. There's two big broad classes. One of them is something called anticholinergics, and the other is called mirabegron, which is acts a little bit differently. If the medications don't work and patients have tried them for at least 4 weeks, 2 different types of medications, at least 4 weeks, we can move on to the next level of things, which include Botox bladder injections. This is something that we place into the bladder in the office. Usually it'll last up to 5 to 9 months duration and works fairly well. Usually I'd say all of these kind of range from the 60 to 80% effectiveness rate. The main thing with the Botox is if it works too well, some women can't urinate for that duration. PTNS, this is similar to acupuncture. What we do is we put a small needle in your foot and hook it up to a small electrical device, and it stimulates a nerve that will go all the way back to your bladder. Usually it includes a weekly session for 12 sessions to kind of get it started. And then once patients are really well optimized, then just once a month. A more permanent type of option, a surgical option, is this implantable nerve stimulator. This basically goes down to one of the nerves that stimulate your bladder, and it sends electrical signals constantly to kind of reprogram it so that it's not so spastic. This is a surgical procedure. My experience has been that the neurostimulation tends to kind of be the most effective, but I kind of reserve this for most of my really severe patients that are having a lot of leakage to kind of justify them wanting to undergo a surgical treatment. Next, we'll talk about stress incontinence treatment. There's non-surgical things that you can do if you aren't doing these already. They're always worth a try. Drinking less fluid. Everybody says drink 8 glasses of water a day. You can drink less than that, as long as you don't have kidney stones. Then it's probably okay to drink a little bit less than that. Things like coffee and soda can help if you stop them. The caffeine component in the coffee and the soda tends to aggravate the bladder. Stopping smoking, losing weight, Kegel exercises can sometimes be helpful. I think the issue is that a lot of times, physicians will tell patients go do some Kegel exercises, but there's not very good, clear instruction on how to do them, and if they're doing the right muscles and activating the right muscles. So usually what I recommend is physical therapists. We do have a pelvic floor physical therapist that works with us here at MarinHealth that just focuses on pelvic floor issues, and she does have some biofeedback. And then the other thing is that there are machines that you can buy on Amazon that you can get feedback to make sure that you're contracting the right muscles. Finally, a pessary, and then a bulking agent, which is something we inject into the urethra. Usually I'm not a big fan of the bulking agents. They tend not to last too long. They'll last maybe 1 or 2 years, and then you have to do them, inject them again. Next, we'll talk a little bit about the Sling. This is basically a hammock that goes underneath the urethra to give it some support, so that whenever you cough, laugh, or sneeze, the urethra has something solid to kind of compress against. This is a picture of the sling here. It is made of mesh, and I know some women have probably seen those lawsuit commercials on the air about if you've ever received any surgical mesh. Usually, the way that I kind of counsel patients is that the material is FDA approved for stress incontinence. There's nothing intrinsically wrong with the material itself, but that the placement of where it goes is kind of the most important thing. Some of the other risks that might happen: injury to bladder, bowel, blood vessels, and nerves. I know this sounds kind of scary. This is just kind of general, though. I usually don't see this at all. Bleeding, infection of the urinary tract or wound infections. The main sort of risk that I see is some women have trouble urinating or develop new urgency symptoms after having the sling placed, just because it does increase the resistance to the bladder. And so if it's too tight, then some women have trouble urinating. And then finally, just problems related to anesthesia used. So let's talk about some of the risks and benefits. The benefit of the sling procedure is that it's short. The surgery itself usually takes about 10 minutes, 15 minutes for me. So it's a quick in and out outpatient procedure. The recovery time tends to be pretty quick. Usually I just tell most women, try to take it easy for about 4 weeks, but for the most part, most people are up in about a day or a few days after surgery. Now, some of the risk: mesh erosion. In some women, if the tissue in the vagina just doesn't heal over the mesh very well, sometimes the mesh can be exposed. It's not the end of the world. A lot of times, what we can do is just give some estrogen cream in it. It'll close it up again, or just remove that portion of the mesh that is exposed. Infection, long-term pain, and then injury to the bladder or other pelvic organs during the placement of the sling. So what are some of the expectations when you're recovering? Usually discomfort's just a few days to weeks. I try to limit people from doing too much heavy exercise or strenuous lifting, but walking around is not a problem. And then one of the things they may notice after placing this is that it may take a little bit longer to urinate. It might be a little bit more difficult, and the stream may be a little bit weaker. Next, I'm going to just talk real briefly about pelvic organ prolapse. This is when the pelvic organs, such as the bladder, uterus, rectum, or vagina, and small bowel, fall from their place in the abdomen and kind of come out through the vagina. So some facts about pelvic organ prolapse. It's not as common as stress incontinence, but it can still be pretty prevalent, about 3.3 million. Half of women between 50 to 79 say they have symptoms of it, and these symptoms can feel like, pelvic fullness, or the worst case is if you feel like you're sitting on like a tennis ball, then usually that's pretty indicative that that the organs are coming out. So a lot of procedures are done each year to treat pelvic organ prolapse. 1 in 3 women with pelvic organ prolapse have multiple surgeries, and a lot of times they also have stress incontinence at the same time. All right, here's just some insurance stuff. Yeah, so all these procedures, like the sling procedure that we talked about, the Botox, the acupuncture, all of these are covered by Medicare. And so none of this stuff is experimental. So, and then if you have any more questions or just are looking for more patient education stuff, this femalepelvicsolutions.com website has some really good information. So you can always check that out to find out more. All right, and that's it. So yeah, I see there's a few questions that kind of came in here. So I'll go ahead and answer them. How many times can you do Botox? So you can do Botox as many times as you need. I know that some people are concerned that maybe receiving too much of it might lead to the body becoming resistant to it, or that there's like these side effects from receiving it so often. But whenever they've looked at it in studies, some women have received Botox up to 10, 20 times without any like long-term complications. So it's possible to do it and not have side effects from receiving it so often. Are you accepting new patients? Yes, I am. So I'm located in Greenbrae as well as in Petaluma. So at the end of this webinar, I think it'll shoot me to my contact information page, and so feel free to check it out, and I'm happy to take a look and just kind of see how we can help you out. Does the sling also fix prolapse? So the sling, the mid-urethral sling that I showed you about, which helps with urinary incontinence, unfortunately, it only acts on the urethra, and so it doesn't fix prolapse if, say, your bladder is coming out or if your rectum is coming out. Usually, there's a different type of procedure or mesh that might need to be used to attach it. And then the way that I kind of analogy-wise explain how what ends up happening with the prolapse is that after a hysterectomy or after childbirth, the things that hold the uterus in place end up getting stretched or cut, and so we try to reproduce that suspension by either using mesh or using some sutures to kind of bring it back to its anatomic position. And then, how quickly can I get back to work after a sling procedure? I mean, I would say it depends on your, what kind of activities that you're doing at work. If it's something that's kind of strenuous and involves a lot of heavy lifting, I'd probably say try to take it easy for at least 2 weeks. But if it's something that's just mostly like clerical or sitting at a desk, usually 2 or 3 days after surgery, most people feel good enough to be able to get back to work. Other kind of limitations after sling, I tell most people don't have intercourse kind of while it's healing up for probably a good 4 to 6 weeks, and also don't go swimming. Usually we put these sutures in that are dissolvable, and so it's just soaking them in water tends to make them dissolve a little bit quicker, and plus it just kind of increases the risk of infection and complications. So my experience with the slings, since it seems like a lot of people are curious about the slings, the success rate is pretty high. It's 90-95% success rate. They tend to be pretty durable. I have a lot of women who ask me, how long is this going to last? Am I going to need to do this again in the future? And usually the way I respond is that about 10 years out, about 70% of people who were dry continue to remain to be dry. And then out of the other 30%, if the incontinence comes back, which sometimes it can, as as people age and the tissue just continues to not be as strong as it used to be, the fix for it is pretty straightforward. Usually I just put another sling right on top of it. So it's not a really involved procedure to fix it if it does kind of come back. Any other questions? All right. Well, thank you so much for taking your time out to listen to this. If you have any friends that weren't able to make this webinar, we went ahead and recorded it so that this link that you guys clicked on, it'll have a recording of it. So